My task is to swing pretty violently in a forward-looking direction in terms of trying to resolve this question of whether we will or will not see powerful predictive biomarkers of checkpoint blockade in the years to come. Enormous list of disclosures. None of them are relevant to today's discussion. Does the pointer work here? Nope, I guess I have to go with this. Except for the ones on the bottom. So I'm going to be talking about immune checkpoint therapy. So you see here that I've served as a consultant for several of the companies that have agents that are approved in this space, but the companies closer to the top of the list are not in this territory. Okay, so as you've already heard in lectures prior to mine, yes, the immune system's complicated, and the tumor microenvironment and its immune constituents is complicated, I'll admit. So there are a lot of populations that could play a role in determining response or resistance to immunotherapy. And is it imaginable that we'd ever be able to deconvolute a complicated sort of collection of cells interacting as depicted in this cartoon? Most of the focus has been on tumor-infiltrating lymphocytes, as you know, and I'm going to try to sort of hit a few highlights in terms of data that supports the predictive power of seeing tumor-infiltrating lymphocytes, particularly CD8-positive T cells in the tumor. And there's been, I would say, an expanding focus on other cell populations, including other immune populations, and the ability they may have to predict response, non-response. And then I'll finish with a few comments on the topic of the role of the tumor cell, which is to say, do we have evidence that we can see phenotypes or biology in the tumor cell that relate to either exclusion of immune cells or inhibition of their function within a tumor that relate to this prediction question. Okay, now I'm going to warm up with a couple of comments that don't relate to prediction exactly, but more, who are the patients who do well in the long run on immunotherapy, and before shifting focus to predictive biomarkers. And there are data sets of variable quality emerging on this topic, but I'm going to use non-small cell lung cancer data here. What you're seeing is a pooled analysis of PD-1 antibody monotherapy trials in non-small cell lung cancer with progression-free survival as the outcome on the right-hand side and depth of response on the left-hand side. And a very simple message, which has been seen effectively across all cancer types and all cancer therapy modalities, dating back to conventional chemotherapy, the first generation molecularly targeted therapies, and now in the setting of immunotherapy as well, that the deeper the response, the more likely a patient is to do well. Surprise, surprise. So this is, again, not a major revelation, but was an important point because I would say if you played back the tape to the 2010, 2012 time frame when first responses were being seen to immunotherapy in melanoma, kidney cancer, non-small cell lung cancer, there was the notion that basically all responses were durable. And that if a patient progressed right away, of course, that was bad, but that otherwise patients who had some degree of regression or a true objective response were in the running for long-term benefit. And we've been learning a lot more with longer follow-up that gives us more resolution on outcomes. And suffice to say that patients who have complete responses, this is non-small cell lung cancers, you don't get very many complete responses to PD-1 antibody monotherapy, but I'll show you a little bit later in melanoma, we do see more commonly complete response. These are the patients who do the very best. So if you stratify the patients here based on their depth of response, it's the patients who have the deeper responses who are in the running or most likely to do well in the fairly long term. This is only 12 to 24-month data. And the importance of emphasizing that point that I'll come back to in a moment is that if you follow patients, for example, down here with more time, eventually you will see these patients progress as well. If they have only modest responses or even middle of the road, let's say 50% regression of tumor, so there's a fair amount of viable tumor that remains, those responses absolutely can be durable, but they will not be permanent. In melanoma, we have the longest follow-up data with immune checkpoint antibody monotherapy to make that point now quite emphatically. This obviously relates to overall survival, which is what we and our patients ultimately care about most, not just radiographic events, but overall survival. And it's very clear that the long-term winners are these patients who have the deepest responses. Okay, now prediction is what we're after here, but predictive markers that map to that outcome is what I'm suggesting is perhaps the most relevant association that we're looking for. So it is not a magical event that a patient survives 5 years, it's whether their immune system clears their tumor is the intermediate result. Okay, so, sorry, I just want to make sure I've got my, there we go. All right, so now we're shifting into melanoma data. And I'll admit that we do have much longer follow-up data sets than the one depicted here with 1 to 1.5 year follow-up at the most. Nonetheless, I think this image projects the relevant point that I want to make, which is that even in melanoma with its high response rate, so 40% objective response rate, and about a 10%, roughly 12 to 13% on a good day, complete response rate, we do have a population of patients who have what we call de novo resistance. And a lot of the early biomarker work that I'm going to run through today has really been focused on classifying these patients as being different from all of these patients, right? So kind of calling that the fork in the road. And I think that's totally appropriate in the sense that in a disease like melanoma, if you consider that within 3 months you see this fraction of patients progressing and that rate of progression, if you will, we look at that and say that looks a lot like the natural history of disease as though these patients didn't receive therapy at all. And I say that at the individual patient level, like literally looking at those patients clinically. There's a fraction of patients, about a third as depicted here, whose tumors progress as though they received nothing at all. And I'm putting it that way because we would love to know who those patients are, and we wouldn't give them this therapy, or at least this therapy alone, which is what I'm showing you, PD-1 antibody monotherapy. Rather, we need to be trying other things, and it's certainly in our center, that means a clinical trial, trying something else, which could be a PD-1 antibody combined with something else, or a totally different therapeutic modality altogether. What's becoming more and more clear is the point that I tried to raise on the non-small cell lung cancer data, and is alluded to here, but it's more powerful with longer-term follow-up figures that I didn't bring today, which is that the patients that you see here, where there are progression events happening over time, are patients with stable disease initially, minimal partial responses, so they just make it over the line by clinical trial criteria, deeper and then complete responses, ultimately reinforcing the point that when you get out to 3 years, 4 years, 5 years, and you ask what are the features of the long-term non-progressors in terms of their early events, they have complete or near complete responses, which is to say that their CAT scans almost completely clear up, if not completely clear up. I'm not suggesting CAT scans are some high-resolution biologic measure, but it turns out that's what the data tells us. If you look at complete responders in melanoma to monotherapy PD-1, those patients, when they come off PD-1 monotherapy, which usually in clinical trials happen at about 2 years, they have a 97% likelihood of maintaining their complete response in years thereafter. So a complete response is ultimately what we're shooting for. And what I'm getting at here is that these progression events are happening in patients who don't have those types of deep responses. But the first generation biomarker work is really focused here on this de novo resistant population. What I'm suggesting is we would also like to know, is there a way to discriminate between patients who clear their tumor, complete response, versus patients who have only a partial response? I think that would be important information to be able to make plans in terms of whether we offer patients in a disease like melanoma monotherapy versus some version of combination treatment. Okay, PD-L1 I could beat up with so many different data sets, but I'm using just one slide today to say that PD-L1 by itself has not been a very powerful predictor, and you all who use PD-1 antibody in practice know this. Yes, it's a companion diagnostic in the vast majority of FDA approvals for PD-1 or PD-L1 antibody therapy, but it's not a very powerful discriminator. And there's a few different ways I could make that point, but if you look at a population of patients here, this is actually a mixture of patients, so just kind of makes a more general point about tumor responses shown on the left, and then outcome scored by PD-L1 expression. So if you were to basically try to parse the outcomes based on varying degrees of PD-L1 expression, you'd have a difficult time really powerfully sorting the populations. And this is a point that's been seen within dedicated studies over and over again. So is there statistically significant difference in outcome? Yes, which is why it's been approved as a companion diagnostic. Does it tell you with great clarity who is absolutely going to respond, who is absolutely not going to respond? No. In no tumor type is that the case. Melanoma, which is my home of homes, we don't use PD-L1 testing, as in it's not an approved companion diagnostic because it has perhaps the weakest discriminating power in that tumor type. Where might PD-L1 be helpful in years to come? This melanoma data that I'll quickly run through, deriving from a phase 3 trial that compared PD-1 monotherapy to CTLA-4 monotherapy to the combination of Nipi-Evo, Nivo-Ipi, Ipi-Nivo, suggested, but I wouldn't go so far as to say proves, that PD-L1 actually may be a powerful biomarker when trying to triage patients between monotherapy and combination therapy, at least this combination regimen. So what you're seeing here is that patients whose tumors express really any degree of PD-L1 on the tumor cell, as was assayed in this study, there was no incremental benefit for giving these patients what is fairly toxic combination therapy versus PD-1 monotherapy. So no bang for the buck in patients whose tumors express PD-L1. All of the incremental benefit, this data set suggests, came in patients who were PD-L1 negative. Now, this is, I would say, not a true statement of the universe yet, because this was a subset analysis performed in retrospect, was not adequately powered to make this point. But certainly, you could imagine a prospective study being able to show a difference in outcome based on this observed effect. We'd like to see that prospective data in an adequately powered study. And if we saw this in melanoma, we would certainly use PD-L1 testing to decide who should get monotherapy versus combination therapy. But this is perhaps the most powerful discriminating outcome ever seen with PD-L1 testing. As you know, Ipi-Nivo now has rolled out in a couple of other tumor types, so this might be a relevant signal or use of PD-L1 testing in the future. Okay, now PD-L1 people have beaten up for its predictive power, partly because it's a labile biomarker, so its expression on tumor cells at least is changeable, and it kind of depends on when you do a tumor biopsy, how proximate that is to the initiation of therapy. That could potentially influence the status of PD-L1 going into treatment. So there's been some interesting work done trying to understand, well, if it's not super powerful at the time that you start therapy or the day before, if you were to test it then, can you use it as an early response marker? Now, I'm not suggesting you want to do this in clinical practice. What's shown here is data from serial tumor biopsies at baseline and then after one dose of PD-1 therapy, basically another biopsy done, and reassessing at that point various biomarkers. And what you can see basically on the left-hand side, looking first at just CD8 positive T cells in the tumor, that in the pre-treatment specimen, the presence of CD8 positive T cells, which as I'll show you in a moment correlates quite nicely with PD-L1 expression, does not really powerfully discriminate response and non-response. There is some discrimination, yes, but the much more powerful discrimination comes after one dose, where at this point basically the tumor and immune microenvironment have gotten itself in order, which is to say on the way towards responding to PD-1 therapy, so just 3 weeks after the initial initiation of therapy, in those who are going to go on to respond, but if the tumor can't get its act together, or the immune system its act together after one dose, then you can see that this kind of measure becomes much more powerful. Now, I'm not suggesting you perform serial biopsies in routine practice, but could you imagine an imaging strategy or a blood-based biomarker strategy where we could actually assess what's happening after the initiation of therapy? What I would say to you is if we can't get our act together and figure out powerful predictive biomarkers, we're going to be looking at early on-therapy biomarkers or relying on them to tell us, rather than after 4 doses of treatment, for example, after a single dose, are patients headed in the right direction? And there's some very interesting imaging methods that I'm not going to talk about today that may be applicable to this issue. Okay, well, what's the best sort of aggregate data we have that if we were to pan back a little bit further from just PD-L1 as a single marker to a somewhat more complex signature, if you will, that we could come up with better response prediction? This is data that's now aging a bit, melanoma data, PD-1 antibody monotherapy, where I'll start with PD-L1. I've already beaten up on PD-L1 as a predictive marker, and this data reproduces that complaint, which is to say that there are tumors, patients' tumors who respond where the baseline expression of PD-L1 is in fact quite low. Admittedly, the progressors are pretty much all low in this data set, and then in the responding population, you'll find some that are high. But you can't really discriminate between these two populations with PD-L1 alone. Shift over here to the T cells that are producing interferon gamma that then trigger the production of PD-L1 on the tumor cell. If you see infiltration of CD8-positive T cells, you see arguably not much better discrimination between the responder, non-responder population, maybe hinting that it's actually slightly better. What's more powerful is if you look at a marker of activation of these CD8-positive T cells, so granzyme B being one marker of activation, what you're seeing here in this group is an obligate subset of these patients who have CD8s in their tumor. Otherwise, you wouldn't see a marker of activation on those CD8s in the tumor. So not just having the CD8s, but having them activated, that's what tells you with reasonable discrimination here, the likelihood of response and non-response. This is not part of routine clinical practice. I would argue this data is suggestive enough to warrant prospective validation, but it hasn't been attempted at large scale. There are various studies ongoing now, going a bit beyond this, as I'll allude to. So really, I think where the field has moved in these more recent years since these initial suggestions that the sort of simple strategy of looking just at CD8s or PD-L1 expression have been more expansive measures of tumor inflammation or hot versus cold phenotype, as alluded to here in this figure. So various attempts at that have been undertaken. One of them is to say, well, if just the presence of the CD8-positive T cells doesn't tell you one way or another whether someone's going to respond, and if PD-L1 expression is so labile and depends on the day that you measure it, perhaps you could look at essentially the intersection of the two, which is interferon gamma production in the tumor microenvironment. That should be coming from immune cells, and CD8-positive T cells contributing a fair amount of that. And there is a gene expression signature that's been relied upon in translational studies and now attempted in human application. In this initial paper, fairly small subset of patients, I'll admit, but it's been validated to a degree in larger numbers. In this initial paper, looking at a 10-gene signature, so at the RNA expression level, so not a very complicated signature, those tumors that were interferon gamma high were very likely to respond versus those that were low, with admittedly troublesome outlier like this one here. So suggesting that basically if you can take the temperature of the whole tumor microenvironment, not just look at individual cells or an individual labile protein like PD-L1, this might give you more powerful discrimination. And there are larger scale validation studies ongoing right now to see if this might be more powerful. This is how that maps to progression-free survival. So this is definitely the type of discrimination we would like to see. I just would caution you that this is fairly preliminary data. Definitely need larger numbers of patients and more follow-up time. But if you really could discriminate between those patients who have essentially no ability to have a long-lasting response versus the patients who occupy the tail of the curve, I think this is the kind of biomarker that we would use in clinical practice. So in our own group, we've taken, I guess, a step further back, or we've used a higher resolution microscope, or higher power lens on our microscope to try to resolve this problem by doing single-cell RNA sequencing. For those of you who don't enjoy looking at this data, I'm not going to force you to look at it for very long, but suffice to say that if you sequence the RNA of individual cells taken from a tumor biopsy before the initiation of PD-1 antibody therapy, and in our studies, in an ongoing way, we will serially biopsy patients to see what changes over time. You can get a universe of information in terms of immune cell populations coming from a single needle from a patient's tumor. And we were hopeful that this approach might be useful because of the hints that were coming from the other data sets, that there were some immune cells, particularly CD8-positive T cells, that seemed to partially predict. How about if we looked in a deeper way at that population of cells, or in an unbiased way at other populations? And it turns out that, in fact, it is the CD8 T cell compartment that seems to provide the most powerful discrimination. So Moshe Saad-Feldman, who was the first author of this paper, published late last year in Nir HaKohen's group, performed this analysis and is responsible for the labeling shown here. Basically what he did was he started with the outcome data, so the patients who responded or didn't respond to PD-1 antibody monotherapy in melanoma, and then just asked, are there markers or features of immune cells that will sort response, non-response in an unbiased way? So CD8-positive T cells were most able to do that, and in that you could discriminate actually two populations that he labeled B and G. B was for bad and G was for good. So the good ones associated with response. And what I mean by that is it turns out that a ratio of good more than bad, literally a ratio greater than 1, was the marker that associated with likelihood of response. And if you had a ratio less than 1, a lack of response. And that's shown here. So if you look, for example, in this set of samples, what you're seeing here is the ratio actually flipped. So this is bad over good. What you would like to have then, if it's bad over good, is a low ratio. Turn that around. You want a high ratio if you want good over bad. Those who had an unfavorable bad to good ratio were non-responders here. So more bad over good. And there are some exceptions to that, the ones in the white circles. And it turns out that those tumors had genetic alterations that disabled their antigen presentation machinery. So the tumors weren't showing their antigens. The immune cells were there, but they couldn't get their teeth into the tumor because of a genetic trick that the tumors were playing, which we and others had described in another paper, that can occur. But the responders were this group here, who had a favorable ratio, more good cells than bad cells. And if you look at this receiver-operator curve, what you're hoping for in terms of predictive value is that this blue curve fits right up against the axes shown here. And this came actually pretty close to doing so. And if you accounted for those genetic alterations that disabled the antigen presentation machinery, in fact, you could tuck the curve up a little bit higher. Predictive accuracy, as suggested here, getting incrementally closer to 100% accuracy. So this idea of using a very high-resolution method really gave us a tantalizing feel that we might be able to fingerprint those tumors that have the right cellular makeup to be able to respond, in this case, to PD-1 monotherapy. Now, it turns out you can measure individual markers, not just this complex signature that was derived from this paper. And there's a protein that you can measure with immunochemistry, and we've been validating that in ongoing studies. Skipping over that today because we don't have the final validation data, but it looks promising that, in fact, a single immunochemistry test might be able to replace this very complex method, where we needed the complex method to make the discovery, but then ultimately could reduce that down to a single marker. Okay, let me take a step back and revisit a couple other markers that you've heard about beyond just markers of tumor inflammation, which, if you were to scan this list, those tumors that have the most inflammation at base on the untreated state. So this is cytolytic T cells, so activated T cells in the tumor. If you go from top to bottom, you do get a reasonable correlation with those tumors in which PD-1 antibodies work, but there are some outliers in terms of the response rates not quite correlating across the board. You've all seen versions of this figure. I've been butchering it over the years, and what this is the tumor mutation burden scale, those tumors with the highest mutation burden on the right, lowest on the left, and I've doctored it up with the PD-1 antibody FDA approvals, but I fell behind and didn't update the fact that small cell lung cancer now is a PD-1 indicated population, cervix not yet. And so you can see really that where all the successes had been racked up had been in the end of the spectrum, where there are tumors with the highest mutation burden. Now, this is at the sort of population level. You note that even in a tumor like melanoma, shown here on the right, we do actually have quite a distribution. A lot of these tumors have a lot of mutations because of UV exposure, but there are subpopulations who don't have very many. And you span across all these tumors, and you'll see a similar distribution. So going from this sort of population phenomenon, can we get down to the individual patient level in terms of predicting outcome is a point that I'll try to develop in a couple of slides quickly. It does seem that there's quite a striking correlation between tumor mutation burden and markers of inflammation, right? So if you've got the mutated neoantigens, the likelihood you're going to have a lot of immune cells infiltrating and seeing those antigens does seem to be pretty well correlated. Again, if you look across the sort of sets of tumor level as shown here in this 2016 paper. So these might be highly related. Some of the earliest signals suggesting the tumor mutation burden might sort response, non-response really looked quite promising. It's the more recent data, unfortunately, that doesn't look quite as powerful in terms of discrimination. So I'll just highlight this figure here. If you had high mutation burden, so high number of non-synonymous mutations versus low, it was suggested that the low group basically had no long-lasting responses versus this population who were in the running. And as I said before, this is exactly the type of shape you're looking for in terms of predictive accuracy statistically. When more work was done looking at mutated neoantigens and looking at the instances where mutated neoantigens were present in a subpopulation of tumor cells in a single patient's tumor versus clonal, as in all of the tumor cells, there seemed to be a better ability to predict those who had durable clinical benefit versus those who didn't. So if you had a large number these high blue bars, of high mutation burden and present in all of the tumor cells in that population. Didn't guarantee response, but higher likelihood of response. Over here, you've got patients who have low mutation burden, and some here who have subclonal high mutation burden, who are in the non-responding group. So it started to get to greater resolution, but again, not complete discrimination between response and non-response by that measure. Where mutation burden becomes really unsatisfying, I think, begins on this figure. I'll give you one more on the next slide. So mutation burden, as you can imagine, is a continuous variable. So even if you were to measure it directly with whole exome sequencing, certainly if you try to infer it from a gene panel, which we use in clinical practice when we're doing next generation sequencing, you will come up with a number. And the number that's been used, for example, in this analysis is 20 mutations per megabase, where you say if you're above that, you're high, and you're below that, you're low. In this data set, it looked like there was actually a pretty powerful discrimination. If you were below 20, then really you were out of the running for long-term benefit, and this is the group that was at least somewhat in the running. So this is reasonably powerful discrimination, and here's the overall survival data. The problem, as you can well imagine, though, is in routine clinical practice, you have two patients who come in consecutively with their next-generation sequencing report, one whose score is 21 and the other one at 19. And is it really plausible that that's just magically totally different? That 21 mutations per megabase versus 19 is just a totally different starting point in terms of mutation burden and likelihood of response. Doesn't really seem like that's plausible. And yet those are the kinds of cut points that are being tested right now in ongoing validation studies. But this continuous variable of tumor mutation burden has definitely had, there are data sets that suggest that it is not terribly powerful in terms of discrimination. So here's response outcome on the left, and I'll just point you to the progression-free survival outcome on the right, that if you score based on mutation burden and the likelihood of being progression-free over time, this is not very powerful discrimination. This is in a population of non-small cell lung cancer patients with PD-1 monotherapy. It would be difficult to walk into clinic and really guide patients in terms of what treatments they should pursue or not pursue based on this association data. And I was beating up enough on PD-L1 before and saying, well, it's not a very powerful discriminator, so you don't want to be close to this gray line here in the middle, which means that a coin toss is as good as your biomarker test in terms of predicting outcome. You can see here that in this analysis, again, of non-small cell lung cancer patients, that PD-L1 testing was pretty weak predictor and tumor mutation burden actually was just as weak a predictor. If you put the two together, you got a little bit more predictive accuracy, but not a lot. So I would say that mutation burden, it points in the direction of the idea that there are antigens that are tumor-specific that are being seen by the immune system, and if we had a way of cataloging those in a very specific way at the individual patient level, which is kind of a mind-blowing concept compared to the low-resolution version that tumor mutation burden represents, that might be a way of actually taking the temperature of those tumors that actually have the right makeup of the tumor cell and the right immune engagement that are one drug away from responding. But tumor mutation burden, I would say, is an intermediate biomarker along that path and leaves a lot to be desired. Okay, let me just close quickly with the idea that a lot of the biology in terms of exclusion of immune cells that then relates to non-response to therapy may well be coming from the tumor cells themselves, which is to say they've elaborated mechanisms by which they can effectively repel immune cells. And some of that data began coming from preclinical papers as early as 2015, and this is one of the seminal ones in Nature. It suggested that the beta-catenin pathway, which you've likely heard about, at least in colorectal cancer and other cancer types where it's clearly an important pathway in the pathogenesis of those tumors, has been linked in this paper and now others as being responsible or at least strongly associated with the exclusion of immune cells. This paper actually suggested, in fact, that it is functionally responsible and that you could reverse the phenomenon if you could block the pathway. Problem is we don't have drugs that can do this in real-world clinical practice, so it suggests that there's a tumor intrinsic program that could relate to expelling immune cells. And so that's at least then a potential biomarker to include in our portfolio of biomarkers to integrate into predictive signatures. It would be lovely if, of course, we could counter this with a drug approach and overcome resistance, but that's going to have to wait another day. In melanoma, really interesting paper that came a few years ago that broke down PD-1 responders and non-responders and looked at RNA expression broadly including RNA that was coming from tumor cells, immune cells, which are the panel here on the bottom, and ones that were coming from either tumor cells or other constituents in the microenvironment, fibroblasts, endothelial cells, and the like. The premise of this analysis going into it was the authors predicted that the immune markers were likely going to be the discriminators. And it turned out there was some discrimination in terms of the immune markers, if you look at these heat maps left and right. But much more powerful discrimination came from these other transcripts, most of which actually were tumor-derived. And interestingly, these two markers here of beta-catenin pathway signaling shown out as being amongst the most powerful discriminators. So kind of corroborated that preclinical paper, suggesting in fact that if this pathway is activated in a tumor cell, this being melanoma, that associated with non-response to therapy. This is an interesting marker over here because it relates to dedifferentiation of melanoma cells into a more primordial neural crest-like state, and that's been associated now in this paper and others with non-response to therapy, reiterating the point that some of the predictive power may be coming from looking at tumor cell biology, not only at immunobiology. This is corroborated in yet another data set, which I won't belabor today, but a beta-catenin pathway signature in bladder cancer associating with lack of inflammation and in further work, non-response. So I would say we have a lot of work to do. PD-L1 was an obvious starting point, I think, for the field to focus on, panning back a little bit further to other immune measures in the microenvironment like CD8, activated CD8 T cells, additional markers that I've suggested that can come from higher resolution analyses like single-cell RNA sequencing. They're giving us the suggestion that we might be able to fingerprint those patients who are in the running for having long-lasting benefit from therapy. We need to further develop these biomarkers. It's absolutely critical. In tumor types where we don't give chemotherapy with PD-1, we have this opportunity to kind of take this fork-in-the-road phenomenon, patients who get no benefit whatsoever, patients who get at least some benefit, if not very long-lasting, and apply these biomarkers to guide patients in terms of other treatment choices beyond just these agents. Thanks so much for your attention.